Thank you, Holly. Thank you, Kai. I'm very happy and privileged to speak on this conference today on CKD in elderly individuals. These are my disclosures that are not related to the talk I'm giving. And I was given 3 questions, and I have to say I'm not specifically thankful for the questions I received. The first one is, what is the burden of CKD in elderly patients, and what are predictions for future developments? And I think that's a difficult one already. Second, what is the role of CKD in the spectrum of age-related comorbidities in elderly individuals? That's even more difficult. Third one, how should CKD management in elderly patients differ from CKD management in younger patients? I personally think that's an easier one, but probably very difficult to implement. So all of these questions, each one is huge. And I was told to have 20 minutes. Now I have a little bit more maybe. But still, to pack them all in one talk is not easy. This is a general slide I would like to start with. I titled it, "In Old Age, Other Rules Apply." And why is that? Because we have a much higher complexity in these patients due to their multimorbidity that leads to polypharmacy. We know that. Frailty, cognitive decline, huge issue. And all this has implications regarding the way we diagnose, regarding the way we interpret our results, and then the way we treat. So, first questions. What's the burden of CKD in elderly patients, and what are predictions for future developments? As I said, difficult. Why difficult? Because the data on the prevalence of CKD in old age are still scarce. Because there are not too many population-based or community-dwelling studies in old age that have data on kidney function and damage. And of course, we use other data sources. Sometimes we use the upper end of younger cohorts, for example, with regards data, or CKD, or other high-risk cohorts, but they are not necessarily then representative of the general population. We very successfully use surveys such as NHANES, and sometimes claims or registry data, and if we are lucky, they are linked to laboratory data, but that's not very often the case. And then there are other difficulties. It already starts with the question, what do we mean by old? So if we look back in the literature, like 25 years ago, it already started, I'm sorry to say, with the age of 50. That has moved, right, upwards, luckily, over the last decades. And then there are the very old, so 80 plus, which are even more poorly represented. And I'm actually thinking if they should not become an entity of their own. If we look at our own data, and I know others do, if you stratify at the age of 80, somehow my impression is, and that's actually the good news, once you have reached the age of 80, I'm not saying you're becoming immortal, but these are the survivors, and some of them are really stable. And then, we all know most studies are not even able to apply the current CKD definition because we simply don't have repeat assessments, but most of them still speak of CKD. So now, as the current guidelines get an update, I'm wondering if this definition will stay. We'll see. And we know GFR estimation is especially challenging in old age. We talked about this. The prevalence will strongly depend on the equation, the underlying biomarker, by the way, their assays. And in claims data, CKD stage 1 and 2, it's just badly reflected because it simply does not get coded. And data on ACR and proteinuria in old age is even less often available. So I did this table, and apologies if I did not include data from studies whose PIs are in the room. It's just an excerpt because we don't have a lot of time. I very modestly start with our own study, the Berlin Initiative study, with a mean age of 80, and you see a prevalence of 38% using the CKD epi based on creatinine. And if you look at Icelandic data, they used electronic medical records. And if you look at the comparable age range, it's actually quite comparable, 36, using the same tool, using Morgan's data and Haynes data and Morgan's AJKD analysis, 80 plus, 62%, using CKD epi based on both biomarkers. So I don't think that's surprising that the prevalence goes up here. And then another analysis using enhanced data, 80 plus, 51%, but again using a CKD epi based on creatinine only. And you see the data on ACR. I'm just showing four studies I know, but data on ACR is not very often available. And then there is the issue of what you are using. Are you using single assessment or repeat assessment? And according to this Icelandic study, it does make a difference. But I think the bottom line here is, and that's again from Morgan's study, as age increases, the rate of decreased eGFR steeply goes up. And these are the data from Iceland giving the same message, no matter if you age adapt or not, it just goes up. So, but the question I was given was not really on CKD prevalence, it was on CKD burden, or burden of CKD. And burden of CKD is not necessarily equal to prevalence of CKD. So how do we measure burden of CKD? Well, the burden of disease measures the impact of living with illness and injury and dying prematurely. So we all know, the approximation of the DALYs. Years of healthy life lost from death and illness. However, as this is a controversy conference, I should be critical. However, the disability weighting for the DALYs is done by someone who is totally unaffected by the disease, probably most of the time. So, and again, this system does not introduce the patient as a subject into medicine. So I'm not saying DALYs is a bad thing. I just think it's probably a first approximation and should be modified. And the overall question to that is, what are we actually talking about? Is it the patient's burden, or is it the healthcare systems, the societal burden, or is it both? The second part of the first question was predictions for future developments, and these are, again, enhanced data by Barrett Bowling. Giving projections, he was showing that the number of people with decreased eGFR already went up by 2 million and 1 million in terms of ACR. And projecting this to 2030 and 50, they say due to the growing number of older adults, the absolute number of individuals with CKD will continue to grow. In terms of kidney replacement therapy, this predicted huge wave of old patients needing kidney replacement therapy, that has actually not reached us, as in old age, most patients die before they even reach kidney replacement therapy. Although, if the demographic shift is continue to go as it is, of course we will see more elderly, even more older adults and elderly patients needing kidney replacement therapy or maybe something else. Second question, what is the role of CKD in the spectrum of age-related comorbidities in elderly individuals? And I think that's probably one of the most difficult questions, because we have to ask ourselves, where do we locate CKD in this landscape? Is it somehow the center of the universe, or is it just one among other age-related comorbidities or morbidities, such as, all the things we know, hypertension, congestive heart failure, diabetes, cancer, and so on and so on. So where do we locate CKD in this conglomerate of age-related diseases? And if you think prediction, and there is a lot of prediction, we have a CKD prediction, prognosis consortium, there's a lot of prediction out there. We think in terms of a heat map. But if you think as CKD as a risk factor, we are automatically in the causal pathway. And that looks a lot more complex. That is, by the way, it was an attempt by my group to see the effect of age on GFR slope. And we actually were planning to submit this with our submission, and then in the very end we decided we wouldn't do it because we were just afraid to receive many letters to the editor of people who would disagree with us. And that's called a DAG, a directed acyclic graph, where every arrow is representing a causal pathway. We actually teach that at the Institute of Public Health, and I think it's a great thing to become clearer and more disciplined in your way of thinking what is really going into my model and what is not. But I'm also sure if you give a certain research question to 5 people and ask them to draw a deck, you will get back 5 different decks. So now it's difficult. I think it has to develop and evolve a lot. But as I said, I think the bottom line here, or the overarching aim, is to move a little bit away from purely association studies. That's probably my main message. And generally, I think we have to become more disciplined to really differentiate what are we talking about. Are we talking about CKD just as a marker, an indicator, a predictor that has probably no biologic ground? Is it a risk factor, so really a cause? Is it just an amplifier in the sense of a positive effect modifier? Or is it an intermediate? And of course, it will depend on the research question. But we should be clear before we, when we phrase our question. And also, for that second question, there should be, and there already is, a shift of perspective. And this is a quote from a German geriatrician I was cooperating with, and she told me, you know what, Elke, in most older adults, I don't care about GFR at all. And I was thinking, how can she say that? But she said, our main and overall goal is that the patient stays at home as long as possible and is autonomous as long as possible. And then I thought, yeah, well, somewhere she is, or not somewhere, I think she is right. And saying that there is also a shift from age-related morbidities to what's here called, again from Barrett Bowling, non-disease-specific problems among older adults with CKD, being cognitive impairment, depressive symptoms, exhaustion, history of falls, and so on. And what you can see is that with decreasing eGFR or increasing ACR, the fraction of people who are gathering more of these non-disease-specific problems is increasing. Okay, number 3. How should CKD management in elderly patients differ from CKD management in younger patients? And I always start with this slide. I think after the heat map, that's the slide that also second frequently shown in nephrology conferences. I borrowed it from Bruce Robinson. It's DUPS data, and it shows the extremely high morbidity. The green line is the old people, 65 and older. The extremely high mortality rate after initiation of hemodialysis compared to the younger patients. And I think as caregivers, we are obliged to ask, what are we doing in our elderly patients? And I think we also have to acknowledge that not for everyone that age, hemodialysis is a beneficial treatment choice. So what are the alternatives? What is our repertoire? It's something, and I think for the future, we certainly have to focus much more on home hemo, incremental dialysis, and comprehensive conservative care. And this is what I would like to spend the last couple of minutes on. I was also told that that would be a nice bridging to the next topic. Unfortunately, the data that are out there are not too satisfying. It's observational data only. In terms of life expectancy, we see that patients above the age of 75, they do live longer if treated with kidney replacement therapy compared to conservative management. However, this survival benefit, this will diminish when patients have higher comorbidity, and they all have basically, and poor functional status. And in terms of quality of life, the trends are broadly similar. Dialysis initiation tends to be associated with a reduction in satisfaction with life and an increase in the effect of burden of kidney disease. And this is the Prepare for Kidney Care study. Probably some of you or all of you have heard of it. It was initiated at the University of Bristol. It's just going on. It's an RCT to establish the effectiveness and cost effectiveness of preparing for, they call it responsive management, compared with preparing for renal dialysis in relation to quality and length of life in multi-morbid, frail, and older people with failing kidneys. And there, I just read in KI, there is another a feasibility study on incremental dialysis. So the field, slowly, but it seems to be moving. From surveys and reviews, we know that to many patients, quality of life matters more than simply extending it. It's about symptom control, support of family members to know what to expect and having time to prepare for that. And I also heard that during our breakout group from our patient representative, knowing that healthcare professionals, and I think that is really important, that line, knowing that healthcare professionals are comfortable talking about death and dying, and a continuity and good coordination of care. So patient-centered care and I'm saying this as an epidemiologist who always looks at data, I think it's as important as evidence-based medicine. And as we know, shared decision-making is core of patient-centered care. It needs good and often, very often, repeated communication between patients and caregivers and early advanced care planning. But we look at the data, and that's, it's an Irish study. It says health literacy levels among older dialysis patients are poor, patient empowerment is limited, and their participation in shared decision-making and advanced care planning is suboptimal. So that's rather frustrating. And that's probably for me, to me, it's the most important slide. A lot has been already discussed in our breakout group and also this morning. Communication is key. I think that's a general statement all over the world, but between patient and caregiver, and very often also including the relatives, it is absolute key. And it's a difficult task, probably the most difficult task, because it needs time, it needs training. We talked about this. Who of you during med school was trained in how to lead an end-of-life conversation? I wasn't. We also have to understand that we do most of the talking, which is not always adequate. We should more listen what the patient has to tell us. This is a serious illness conversation guide. There are probably others as well. I just wanted to show it just to demonstrate things are out there. It helps how to start, how to open up such a conversation, to guide through and to end it. But we all know it's so challenging, right? You have to have a room in the literary sense, but also the moment has to be right. No one should disturb you, the phone shouldn't ring. Yeah, it needs time. And I think, Holly, you said that, cognitive dysfunction is something we also have to deal with. It's probably much more common than we think it is, especially in CKD patients. And these are, small to moderately sized studies. There is a British one, 20%, with a mean age of 55, and then 61 cognitive decline in a Canadian study with a mean age of, I would say, just 68. And among dialysis patients, only 30% with normal function. In a US study, 40% mild, 36 moderate, 37 severe functional decline. So how do you explain things? How do you communicate? How do you do this? I don't have the answer. I'm just trying to raise awareness of this problem. There are thoughts to do like cognitive functional screening tests. It's certainly something to think about. It also needs time. It also needs a lot of tact. Not everybody will agree. Not everybody will understand why. So, it's difficult. So, in summary, regarding the first question, the prevalence of reduced GFR, CKD, increases with increasing age, no doubt. Absolute numbers will further increase in the future, but the prevalence of CKD isn't necessarily the same as the burden of disease. And in terms of the second one, the role of CKD in the whole spectrum, we need to differentiate between risk factor, predictor, amplifier, and intermediate. And there's certainly a shift in old age to age-associated health problems. And then towards the last part, evidence from RCTs is much needed and hopefully coming up during the next couple of years, as otherwise we have such big non-comparability between groups, which makes inferences from observational studies very questionable. We need more individualized treatment, including conservative care and probably also incremental dialysis. And I think all of us need more training and communicational skills. And sorry for giving probably even more questions back to you than I received. Thank you.